All right, so I'd like to present our results of reoperations. So we performed over 1,100 reoperations last year and 290 multi-reader heart surgeries, and 50 patients had their fourth or more reoperative heart surgery at the Cleveland Clinic. Outcomes have been excellent. Last several years, our mortality has been ranging around 2 to 3% for all reoperations. Within the STS category cases, we had one death for redo CABG, but no other mortalities among the 233 STS category cases. Between 2020 and 2024, for redo isolated CABG, AVR, and MVR, the mortality has been around 1%, which is much lower compared to the STS data, which is ranging around 3 to 6%. For isolated redo mitral repair, we have had no deaths. Endocarditis surgery has been increasing. Last year, we performed about 230 surgeries, and the mortality has been around 3%. Considering many of these patients are reoperations and very complex, require root reconstruction, I think this is an excellent outcome. About 60 to 80 homograft root replacements every year, again with excellent outcomes. And based on this large experience in endocarditis, we published a book just about endocarditis, over 600 pages. And this project started in 2020. We exchanged over 1,000 emails and was finally published about a week ago. On behalf of Dr. Patterson, thanks to all the co-authors. TAVR explant surgery is another topic that has been discussed at every single major cardiac meeting. Our mortality has been around 5%, which is much lower than what is reported from other centers, which is about 10 to 20% mortality. In Ross procedure, a number has been increasing at our institution as well. Last year, we performed over 30 cases, and many of these cases are some of these are reoperations that have had multiple aortic valve surgeries, and for some patients, this may be the only good operation. And I would like to show one example. So this is a patient that we operated last year, a lady in her 30s who had 4 prior open heart surgery over the years. She had an AVR, a redo AVR, and a third redo homograft. The last 2 surgeries was for endocarditis, and which failed. And then she had a 4th redo root replacement with the Onyx 19 minimum valve. This was a very complex operation that required a cabral graft, and she was open chest for a few days. And so she presented with severe aortic stenosis. One of her discs was not moving well. In addition, she had moderate mitral regurgitation and tricuspid regurgitation. Her distal aortic anastomosis had a kink. Her left main had a kink as well. At her local center, she was told that heart transplant is the only option. And so I got a second opinion, and I looked at the imaging. I discussed with Dr. Patterson, and we thought we can fix the valves. She doesn't need a heart transplant. I'm sorry, there was a video here that showed the anatomy, but it wasn't playing. So what we did was we did a 5th readostromy, circulatory arrest and hemiarch replacement, Ross procedure, and a mitral valve and tricuspid valve repair. Her outflow tract was about 16 millimeters. And she had a large appendage, a lot of surgical material. After we removed all that, it was still very narrow. So we had to enlarge the LVOT with a mini conal incision. The cross-clamp time was 3 hours and 50 minutes. Pump run was about 5 hours or so. But at the end, the LV and RV function was both normal with no AI. She was extubated on day 1, discharged on day 10. I saw her a few weeks ago in follow-up. She had no AI and normal LV and RV function, and she said that she can do everything she wants. This kind of complex operation can only be done with a very excellent team of teams. I'm grateful to have a great team not only during the day, but also during the night as well, because these cases go well into the night. And recently they started assigning 2 fellows on my service so that they don't burn out. Without you guys, this can't be done, and you've done a very good job. So thank you. And again, Dr. Patterson, thanks for Dr. Patterson coming back every few months to continue to teach us. And whenever he comes back, he's probably the hardest working surgeon. This was a picture that was taken around 2 a.m. on a Friday night after he probably has done 2 or 3 surgeries during the day. And I called him around midnight and told him that we have a offer for a lung transplant that could be a suitable candidate for a BAR, a bronchial artery revascularization, which has been his sort of like his life work. And so I called him around midnight. He woke up, came to the OR, and we did another. This was another 6-hour pump run surgery, but went well. And so we hope that you would. I think he's listening, but I hope you'll continue to come back and teach us how to handle these very complex situations. So, thank you.